Let's just talk about a minimally invasive technique to treat patients with pulmonary embolism. And going straight to the point, pulmonary embolism is very common and very deadly. Okay, how common it is? It estimated that one patient on every 1,000 inhabitants will have PE every year. 10% of these patients will die right away in the first 2 hours. 10% of patients will die in the first year. And 50% of patients who have PE plus hypotension will die. And if you don't think that 10% die in 1 year is high enough, the most dramatic data about PE is that the vast majority of patients, 60% of patients, die of PE, and you never knew. It's a diagnosis that you do after they're dead, post-mortem, meaning that these patients, 60% of patients with PE, never had a fighting chance. They never got diagnosed, and they never had a chance to be treated. And we have to go a little back into med school and think about how this works, right? So if we understand this, we can understand how dangerous PE can be. So you have a large vessel occlusion. You have a big thrombus inside the pulmonary artery. That segment of lung is not getting any blood. So what it does to compensate that, it just creates vasoconstriction. That, allied to the fact that you have this clear thrombus obstruction to blood flow, increases the resistance into the right heart. So now the right heart has to fight this increased pressure to be able to pump blood inside the lung. To compensate that, because the right heart actually doesn't deal very well with increased pressures, it just dilates, right? It dilates to try to get more blood in, and by Frank Starling mechanism, try to push more blood forward. So you have increased pressure, this RV is becoming dilated with more blood inside of it, and then when it contracts, blood spills into the right atrium via tricuspid regurgitation. And you keep getting this cycle over and over again. You have increased pressure because you have more blood. You have more dilatation, more blood, more pressure, more dilatation. And you keep going to this cycle until the heart actually becomes tired. You're using too much oxygen, and there's a point where the heart gets too tired and becomes ischemic. So the heart is now ischemic, and because it's suffering, it doesn't contract that well anymore. And if it doesn't contract that well anymore, what happens? It dilates even more. And the cycle keeps going over and over again until a point where the heart is so tired, the blood doesn't go towards the lung. A little bit of blood comes back from the lung into the heart. And that little amount of blood is just not enough to maintain the patient's pressure. They develop hypotension. If they become hypotensive, the coronaries now are suffering because they don't get enough blood. More ischemia. If you have more ischemia, more dilatation. So you can see there's this cycle that keeps going over and over again, and patients just keep spiraling down towards this rabbit hole that we actually call the death spiral. So, and if you understand the pathophysiology of PE, specifically aiming in these 4 points, you can understand the clinical features that show that these patients are suffering a lot. They are at risk. For instance, the RV dilatation, it's something that on imaging we routinely see on echo for patients that are severe. And it's the RV that becomes dilated in comparison to the left heart is the intraventricular septum that becomes flattened. And on CT is the same thing that we see. The RV is just much bigger than the left heart. The ischemic heart, well, this is quite easy. We have the troponins, we have the BNP. All those are markers of ischemic injury to the heart. The lack of contractility of the RV, well, we see this on imaging as reflux of contrast into the IVC or the hepatic vein. Specifically, this patient on image, he arrested on the table. So that's why we see so much reflux. And if you have hypotension, well, that patient will show signs of shock or even cardiac arrest. So exactly these 3 features is what we use to stratify the risk of this patient. The more severe they get, the higher the chance of they dying. So if the patient has a dilated heart, or if their heart is ischemic, well, that's gonna be considered submassive PE or intermediate risk PE. It depends if you're European or North America. And if those patients develop hypotension, that's the most severe sign that they can present with. 50% will die, and we call this a massive PE or high-risk PE. So how do you treat? Doesn't matter the risk of the patient, where they are. Every patient, all of them will get anticoagulation. That's standard of care. And now when we go back to the three main guidelines that we have available for the treatment of these patients, stratifying by risk. Well, okay, the patient who is at high risk, who has hypotension, who is at high risk of dying from PE, is when we indicate a clot buster, the thrombolytics. And the patients who are, well, not hypotensive yet, but already show heart dysfunction or ischemic heart, they will get thrombolytics if they are failing to improve with anticoagulation alone. And TPA is a drug. We've been using it for several years. Several studies have shown that patients who are with these indications and use TPA, they have better outcomes. Their survival increases. They die less. That's great, but it's still a drug that has risks. The main risk that we talk about is the risk of major bleeding. 7% of patients will have major bleeding. And the most devastating type of bleeding that we can have is inside the head. And 3% of patients with PE who are treated with TPA can develop this type of picture that usually is fatal. And not just that, TPA as a drug, there are contraindications. Not every patient is a candidate for TPA. If you put a patient on a TPA drip, they will have to go to ICU to be monitored, of course, because of the risk of major bleeding complications. And it's a systemic injection that you give at the hopes of that drug reaching the lung and breaking the clots and the patient improving. So what does interventional radiology have to offer? Of course, the easiest step that we have to offer is, well, rather than giving the TPA through the vein, why don't we just go inside the heart with this very special catheter that has side holes and drip TPA inside the lung itself? And this is exactly what the pictures show. The picture of the catheter is pure marketing. The TPA does not come out with that amount of pressure. It's not breaking anything. It's very, very gentle drip. On the imaging that we have of the lungs itself, you see one catheter on each side, and that's what we do. One catheter on each pulmonary artery. We keep TPA running over 20, 24 hours, and hopefully that will break the clot and the patient will improve. But CDT is not a perfect technique. The pros are quite obvious. Well, it is a targeted therapy. Everything in IR is targeted. The more targeted you are, the less amount of drug you need to fix the patient. And if you're using less drug, the chances of you having a major bleeding event is smaller. But the disadvantages are you're still using TPA. It's still a drug. The patient on TPA will still have to be monitored on ICU, increasing costs. And of course, we don't have beds to spare. The TPA is very slowly infused. It's 1 milligram an hour, or actually 1 milliliter an hour. So you can see how slow that is. It takes about 20, 24 hours for you to achieve the maximum dose to treat that patient. So on a situation where it's life or death, 24 hours is just a lot of time. You don't have that time to lose. And you're still using TPA, meaning that the same contraindications that you have for the systemic TPA, you have for targeted therapy with IR. Just to name a few contraindications to TPA includes a patient who suffered major trauma, a patient who had a major surgery in the last 2 weeks, a patient who had a stroke in the last 3 months because of the risk of that area of that brain becoming hemorrhagic and bleeding out, patients who are on warfarin or new anticoagulants, a patient who has brain cancer, a patient who is pregnant. All these patients, you see them in London, right? We are a major trauma center, trauma patients. We are a major surgical center, and you can use them in these patients, right? We're a massive stroke center, just like Sachin mentioned, and it just keeps going, right? Brain cancer, we're a huge onc center, and pregnancy, well, we have a very busy Victoria Hospital there. So you can clearly understand that there is a population that we see in our daily practice who can have a deadly disease, pulmonary embolism, and can not, and maybe are not able to be treated as the guidelines tell us to treat them. So what can we offer instead? And that's exactly where we're going to get into. Well, right now, we're diving into using large bore catheters to actually aspirate that clot out. There are two main devices available in Canada. They're Health Canada approved. One we call the Penumbra Indigo, and the other one is the Inari Flow Retriever. What are the pros and cons of aspiration? Well, the pros is quite obvious. You can remove the clot right away, so the patient might improve right away, and we see that in clinical practice. You're not using TPA, so you do not need ICU. You might be saving money there. And of course, if you're not using TPA, there's no risk of the patient bleeding in their head. There are some disadvantages to the system because, of course, it is a big catheter, it's almost like a hose. If you're aspirating the clot out, you will be aspirating blood out. The companies develop technologies to try to minimize the amount of blood that you aspirate out of the patient, but it can still happen. And it is an invasive procedure, and every invasive procedure has risks. For these cases specifically, access risks because, well, it is a large bore device. And of course, it's a large bore device as you're trying to scrape out some thrombus outside of the pulmonary artery. You can actually perforate the pulmonary artery. And this is how it's done. On the image on your left side, you can see the arrows pointing where they're filling defects. Those are blood clots. That's a PE right there. This big device goes in where the clot is. You aspirated it out, and this is what comes out. And patients can improve right away. And if you go back to that slide showing how PE works or how it can kill a patient, well, if you can imagine that you're putting an aspiration catheter right at the front, right at the basic principle of taking that thrombus out and decreasing the occlusion, the obstruction, and improving the values of constriction, you maybe be able to prevent all the other things from happening. And this recent study, it doesn't matter all the data points that they show, but this is very recent, and this is important to us because this was actually the first trial that looked at mortality, looking at, is this technology able to decrease mortality and make patients live longer? 11% of their 800 patients had contraindications to TPA. In other words, patients that had no other treatment options and still were able to be treated with aspiration thrombectomy. And what I would just like to focus at, the mortality at 30 days was less than 1%. And that's very, very low. Just to make a comparison, although we cannot make a direct comparison because it's two different studies, but a Harvard study with a patient population not that different from the study that showed a very low mortality, but a study where people couldn't use aspiration showed that mortality was 16%. So you can clearly see that if you aspirate the right patients in time, you will be able to decrease the mortality of this very deadly condition. In our experience right now, we have roughly 12 cases. I'm just going to highlight two that I think are very important. One was a 16-year-old who had a very bad car accident, came into Victoria with multi-fractures, several areas of bleeding inside the head. So again, you cannot use TPA to treat this patient because things will just get much worse. He had an aortic injury, again, contraindication to TPA. And he became unstable and required more drugs. So we did a CAT scan, and then what we saw is what we call a saddle embolus. So it's this elongated thrombus occluding both pulmonary arteries at once. He was massive because he was struggling with his pressures. He needed drugs, but he had contraindication to TPA. So if we did not have this technology available for this patient, he would have died. Period. And this is what we did. The pictures that we acquire are not that pretty because you do not want to overload that heart with more volume from contrast. You don't have much time to lose. You know where the thrombus is. You just go after it. You chase it. You aspirate it out. And hopefully the patient improves. And this is exactly what happened to this patient. He was able to go to his home hospital and treat all his other injuries after he survived a massive PE. In this other case, a 20-year-old presented to the emergency department just feeling unwell. She had diarrhea, abdominal pain for the past few weeks. 2 months before she presented to the emergency department, she broke her foot, so she wasn't moving a lot, and she was on the birth control pill. So while she was being assessed on emergency, she became unresponsive, pulseless. She had a cardiac arrest in front of the doctors. They did 40 minutes of CPR in her and gave her all the drugs that were available, including TPA. She came back hopefully. And then we performed a full body scan to detect what was the cause of her arrest. For her case was, again, bilateral pulmonary embolism, and she arrested, so no time to lose. We went just ahead and aspirated the clots out, and the patient actually went home a few days later. And again, this is a patient that, if we didn't have this technology, might have not made it. So what are the challenges for implementation of this technology in our LHSC? Every time we talk about a new program, the keyword is sustainability. Sustainability is not just money, throw me money and I'll do it. The three pathways that I like to look at are patient flow, human resources, and hospital resources. I'm just going to focus on patient flow and human resources. Patient flow means you're capturing all the patients who might benefit from this technology, and just to create this continuous patient flow so you can perform the procedures and help the patients that you think will be able to be helped. And human resources means, well, getting the team ready to do a procedure that we've never done. This includes IRs, this includes nurses, this includes MRTs, because again, we've never seen this done before. Specifically about patient flows, the way we overcame this is, well, we created a research group, IR, ICU, and thromboses. We established very specific criteria for aspiration. We will be aspirating all patients who present with massive PE, because that's a life-threatening situation, no time to lose, do what's best. And all those patients who have submassive and already got TPA but did not improve, or patients who are declining and have contraindications to TPA, this comes in as an alternative and hopefully making them feel better. This research group also allowed to capture patients throughout the hospital. For instance, getting ICU involved was crucial because every patient who gets TPA goes to the ICU. So ICU now is aware if a patient is declining, maybe aspiration is the next step. If a patient is too sick at the ward or in the emergency department, they will call the ICU outreach team to evaluate that patient. So again, that's ICU evaluating that patient, and then they can decide if aspiration is beneficial. And having thrombosis involved is also crucial because once a patient starts failing anticoagulation, they call thromboses to get their input. And again, we might be able to capture those patients who are more likely to benefit from aspiration from that pathway alone. This also generates a database. So REB is pending right now. The database, all the data generated will allow us for quality improvement. How are we treating patients with PE in our hospital? Well, we will be able to measure outcomes and see if they're comparable to what the literature says. And of course, we're now generating Canadian data, and hopefully we can present it to the province for this to become a funded program that right now it's not. Human resources means, well, IRs, the way we do this, usually 2 IRs at once because we're training each other and getting used to the devices. We have a proctor on site with us to do the cases. So again, it's a new technology, a new device. We need to know what we're doing. And we also now have a signed agreement with industry-specific company that will give us free devices so we can start doing more cases. And this will also allow us to become a center of excellence for this company so we can be enrolled in their future trials. And this is actually, we're almost there. Yeah, we're almost being enrolled in a very significant trial for PE. When it comes to hospital resources itself, I'll leave it on for Paul T. It's all yours.
Thank you, Leo. Thank you, Dr. Paul, for this opportunity to talk about this very exciting new therapeutic option for life-threatening pulmonary embolism. Leo has provided you with an excellent overview of PE classification, current therapeutic options, the decision-making process, and all the ways that mechanical thrombectomy helps our patients. I get to share with you all a little bit about the administrative process. So he described the delicious sausage, and now I'm going to tell you how it's made. I have nothing to disclose. So once we decided that mechanical thrombectomy was something important to offer, we needed to establish that there were some Health Canada approved devices available. At the time we started this process, there was one, and there was one almost ready for the market. And the decision was made to move forward with an application within our administrative structure for clinical use of the system that had existing approval. That was the suction thrombectomy system. Many of you are no doubt familiar with the rather large costs associated with running an IR service. It's a device-driven, multidisciplinary and multimodality, minimally invasive surgical environment where the scope of services is continuously changing and the iteration of the myriad tools that make the work possible. As well, new devices are always being introduced, and every so often a whole new procedure manifests itself based on a breakthrough in biomedical engineering. I have only a few minutes with you, but I will focus on how to get from the clinical solution to implementation. This can be a daunting process, but having cycled through this a few times now, I think it's a fairly routine series of steps that can take patience and persistence, but ultimately require no godlike powers. Bureaucracy is baked into every large institution and hospitals with our focus on safety and appropriateness on the one hand, and innovation and research on the other make for a tense balancing act whenever change is contemplated. The surgeons at Sick Kids were grappling with this very issue about 10 years ago, and I am grateful that they took the time to share their process in this 2015 publication in the Annals of Surgery. Sick Kids defined innovation as a significant change in clinical procedures, techniques, technology, devices, and treatment or therapy that have not yet been introduced at the local site but have been validated elsewhere. Formal approval is required before introduction for these innovations that A, have significant cost implications, and or B, pose sufficient risk that independent review would benefit the patient, clinician, or staff person and or hospital, particularly in the event of an adverse outcome. So why is such a challenging administrative path necessary before we can try new things? Well, precisely because not all innovations are beneficial to the patient. Beyond that, hospital oversight has its foundation in the law. Under the Public Hospitals Act, as well as the somewhat younger Excellent Care for All Act, the hospital's board of directors has a fiduciary responsibility to its patients. In general terms, that means that the board has a legal obligation to ensure that the hospital behaves in the best interest of its patients. Not doctors, not managers, not employees. The patient's interests are primary. This requirement to protect the interest of patients trickles down to the delivery of services through hospital governance, one area of which is oversight. In medical imaging at LHSC, oversight is provided by our very own Medical Imaging Executive Committee. Oversight over new procedures and devices requires a good understanding of not only the finances of the hospital and the medical imaging departments, but also an understanding of all the labyrinthine funding programs that are offered by the government of Ontario through its various funding arms like Cancer Cure Ontario. IR generates almost no TFE revenues, so all of our procedures must either be funded out of the general departmental budget or be offset by Ontario Health funding plans like those for thermal ablation, TACE, radioembolization, stroke, and spinal augmentation. Periodically, the government will review new procedures, and if the review is favorable, introduce funding which can be applied for. Unfortunately, when these funding plans are introduced, the Ministry has typically taken a look at any department's activity and assigned reimbursement for only new volumes of procedures, and it is thus important to try to time new procedures with funding, or for innovations like we're proposing here at LHSC, limit procedures to research until funding is introduced in order to avoid the dreaded base volume. Might be difficult to see here, but in 2016, mechanical thrombectomy for acute stroke was favorably reviewed by OTAC, and funding followed shortly. Venous mechanical thrombectomy was similarly blessed by OTAC this past January, so it seems likely that funding will be introduced in the next couple of years. Failing to plan for this could cost medical imaging tens of thousands of dollars a year forever. The first step to any goal is the hardest, and it's no different here. We started collecting data. There was the obvious precedent of acute stroke intervention, And that became an important comparator. Strengths and weaknesses of current techniques would be compared to the strengths and weaknesses of mechanical thrombectomy. And then there was no escaping dealing with costs. But understanding the costs start with understanding the scope. And it's challenging to find reliable PE data in Canada. There are a few papers and reports available, and this allowed us to estimate that we have approximately 2 to 3 patients a month facing a life-threatening PE in London, where the availability of mechanical thrombectomy not only would drastically improve their chance of survival, but also accelerate their recovery and limit the constellation of post-PE symptoms and recurrence that so many patients experience. Knowing the scope of the problem, or opportunity, as I like to think of it, is key to estimating both the cost to medical imaging as well as the savings to the larger health system. At UHN, the pitch document is called a business case. Here at LHSC, we call it the briefing note, and it is essentially an executive summary of the proposed procedure, the rationale, the costs, and the scope or impact. I generally follow the SBAR model for communicating this, which is situation, background, assessment, and recommendation, and attach relevant key publications to the medical literature. Given that venous mechanical thrombectomy is a more costly procedure than existing catheter-directed thrombolysis techniques, it was felt we needed to highlight the system-level financial benefits that result from this new life-changing technology. It was key to assess the costs beyond the silo of medical imaging in order to paint a fulsome picture. Dr. Leite networked extensively, and his colleagues across the hospital kindly agreed to share their clinical perspectives on the importance of LHSC offering this procedure to our critically ill PE patients. And those perspectives were an important element of the system-level element we wanted to emphasize. The proposal had to anticipate as many criticisms as possible. Does this replace another technique or procedure? Is there evidence to prove it's better for patients? Is it more or less expensive? Is there funding? And why do you keep asking for so much money, Paul? At the end of the briefing note, it's important to provide a realistic assessment, not only of the costs to medical imaging, but the savings to the larger hospital or healthcare system, acknowledging that freeing up an ICU bed doesn't always necessarily mean another patient won't appear to fill it. In our note, we estimated that the bed spacing savings alone would dwarf the costs associated with the procedure by tenfold or more, but the real benefit would be the saved lives. I'm pleased to report that venous mechanical thrombectomy was approved for clinical use at LHSC under a research umbrella. This, in my view, is the best possible outcome. Better care for our patients, while at the same time contributing to the pool of knowledge that will feed back to the next innovation and the next briefing note. Thank you for your attention.